a motion to accept.
Motion to accept the agenda.
Second.
All right, it's been moved and properly seconded. Are we ready for the vote, Ms. McLean?
Yes, sir. Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Commissioner Alam, Dr. Jackson,
Yes.
Dr. Braithwaite,
Yes.
Dr. Orto,
Yes.
Dr. Brown, excuse me, Mr. Brown,
Yes.
and Dr. Glover. Thank you.
Thank you. Again, hopefully everyone has had an opportunity to look over the minutes that were disseminated earlier. If you have, well, either way, I will accept a motion to approve the minutes as printed.
So moved.
Second.
Seconded.
All right, it's been moved and properly seconded. Is there any unreadiness? All right, we're ready for the vote, Ms. McLean.
Dr. Braithwaite,
Yes.
Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Commissioner Alam, Dr. Jackson,
Yes.
Dr. Orto, excuse me,
Yes.
Mr. Brown,
Yes.
and Dr. Glover. Thank you.
Thank you. So we're all aware that our director, Rod Jenkins, is away in London working with his, doing his doctoral work, a portion of his doctoral work. We are blessed to have our deputy director, Liz Stevens, on camera on the call. So Liz, I will give you an opportunity to have any staff or program recognitions at this time.
Wonderful. Thank you so much, Chair McDougall, and good evening to you. Good evening, Attorney Wardell, and to this wonderful board. It's really a pleasure to be in front of you and on camera this evening on behalf of Director Jenkins, and good evening to our staff here as well. So I do have two staff and program recognitions to share. I know the first Director Jenkins shared with you all via email earlier this week, as we are in the midst of celebrating Nurses Week 2023. It's of particular pleasure for me to share this, being a public health nurse myself. So as you know, we have many nursing professionals here in public health, and we honor them and we thank them every day. But this week in particular, every May, we are given a chance to really recognize the work that they do. The theme this week, which is set each year by the American Nurses Association, is "You Make a Difference." And we certainly know that our nurses do. And we hope that they know that. And as leadership, we know that it is our task to be sure that they do feel appreciated and that they do feel like they are able to do this good work for our community in a supported environment here at Durham County Public Health. We have 81 nursing professionals in our department, to include nursing assistants, registered nurses, nurse practitioners, and of course, a number of contract staff. And I would be remiss if I did not recognize our Director of Nursing, Hattie Wood, here with us this evening and steadfastly leading this group of professionals as she has for many years. I myself have learned a lot from Director Wood, and I thank her as our chief nurse in the building here. We know that nurses are at the backbone of a lot of what we do here at Public Health, and we certainly saw this during COVID, and they show us every day. So on behalf of our department, I would love to share with this board our celebration of our public health nurses this week. My second staff recognition is to recognize one of our veteran leadership team members. And I did check with her prior to our meeting to ask if she would be willing to come on camera and just say a few things. Michelle Easterling is going to be retiring at the end of this month. And it's been a true pleasure to work with Michelle. She's graced us with her expertise, her humor, her kind spirit for more than 33 years here at the department. For the last 12 years, she has served as our nutrition division director, as you know. During her tenure with us, Michelle has grown the division, starting, I think she shared with Director Jenkins and myself, the division started as perhaps half a dozen staff when she first joined public health many years ago, and now has grown to more than 30 positions. And I really, truly credit Michelle's leadership for a lot of that success. She's a seasoned leader. She was instrumental in our early COVID days, as some of you may remember, taking on interim roles in our COVID response. And I can say that personally, over the past 2.5 years that I have served as her supervisor, she has taught me a lot. So Michelle, we honor you, we thank you, and we will miss you. And if you would be so kind as to share your words with this illustrious board.
Well, thank you, Liz, for recognizing me. And it has been a great ride. I've seen so much. You can imagine 1990. And some of you, I remember working with Dr. Jackson in the old building when she was a new physician in our women's health. So that was fun. Just been a great ride overall, very positive. Worked with about 5 different health directors. So that's been interesting. And all along, I've felt the great support of the Board of Health. So I just want to acknowledge the existing board and thank you. And I don't think we could have grown without your interest and your recognition and support when we have a grant or we are requesting a new position. It's been because of the Board of Health too. So I just would like to thank you all for that.
Thank you,
Well,
Michelle.
thank you, Michelle. Thank you so much. You know, I have a soft spot for you and for nutrition.
I do.
So thanks for all the hard work that you've done over those many years, because I don't know that I would have lasted 33 years. So thank you and congratulations.
Thank you.
Thank you so much, Chair McDougall. Those are the recognitions I wanted to share this evening.
Okay, thank you, Liz, for those recognitions. And I want to echo your sentiments and thank once again all of our nursing staff, as well as Michelle, for all of your many years of hard work and dedication to the board, to the public Department of Public Health. Thank you.
Thank you.
All right, so we're going to move on to our administrative reports and presentations. We have Ms. Cheryl Scott here with us to present on behalf of the Community Child Protection Team. Ms. Scott.
Oh, yes, good evening.
Good evening.
As you said, I am going to present on the, excuse me, I'm going to get my screen up. Okay. Is everyone able to view my screen? Wonderful.
Yes.
Okay. Great, thank you. As you said, my name is Cheryl Scott. I'm a program manager here in public health, and I'm also the review coordinator for our Durham County Child Fatality Prevention Team. In Durham County here, we have a joint team, a combined community child protection team, which is overseen by the Department of Social Services, and our child fatality prevention team, which is overseen by the Public Health Department. The Child Community Protection Team, they examine deaths due to neglect or abuse for children, and the Child Fatality Protection Team review child deaths from birth to 17 that are not due to neglect or abuse. And I'm going to begin at slide 12. The beginning of the presentation really just speaks about membership and positions. And I really want to talk about, so as not to take up you all's time, and you do have the report there with you and a copy of the presentation. I really want to go right to the summary of the identified systemic issues and the recommendations that we have. And I can incorporate some of the examples of the cases we see that are relative to this. Okay, a lot of infant deaths in Durham, they appear to be related to unsafe sleep environments. And this has been a really cause of concern for the joint team, because we see a lot of child deaths that are they're undetermined. But when we read the officer of the chief examiner's medical report, it will say that the child was co-sleeping with the parent. The child was sleeping with the parent and the parent woke up and was on top of the baby, or the baby was in the bed rolled over and ended up in a stack of clothing or some clothes. And these babies, we've had a few these past couple of years. I've only gone back a couple of years, but we've had babies from 1 to 12 months. And it's been determined to be co-sleeping, undetermined for a lot of them, asphyxia, which has to do with a baby turning over and not being able to turn back over. So we're developing what that gets a recommendation. I don't want to get to that too quickly, so excuse me for that. Also, there's a lack of health insurance for many parents of children in the child welfare system. And this is because a lot of parents missed that cutoff for Medicaid, maybe by a few dollars, maybe by a few $100s, so they were ineligible. And as a result, they were either underinsured or ended up with no insurance at all. We also have undocumented individuals who come and they are unable to access insurance for themselves, although their children are American citizens. So if we don't have a healthy parent, we're going to have a less likelihood of having a healthy baby. They don't have the way to get the child there and to also take care of themselves. And if they don't have access to public or state or private funding. Then the next is community access to low or no cost grief counseling after the deaths of infants or youth. And this is something that we've been trying to locate as a team because we've had siblings to find a baby deceased in the bed. They've been babysitting a teenager. And we read the report and we ask, well, what was done for this child? Because there's no mention of what was done for this child who found their baby brother or sister not breathing, or what is done for this parent who is not able to shake this grief, or who can we refer her to for some assistance? Who can we refer the family to? There are caregivers that are affected, their grandmothers, grandfathers, aunts, uncles. So what we're trying to do now is to build a resource, but that comes later as well. Excuse me, I'm just jumping ahead of myself. Our next concern is the number of young children accidentally accessing fentanyl in homes is increasing. It's leading to death or near-death experiences for children. And we've seen this as such a teenager, 17 years old, parents had no idea that this child had a drug problem, and the child so happened to get a hold of some fentanyl and took too much. So mom comes back in the next morning to wake the child up for school, and they don't wake up. Or there's a baby, the dad is a suspected drug dealer in the neighborhood. Some way he had powdered fentanyl on his shirt, picked up the infant, laid the baby down on his chest to sleep, and the baby died. The baby inhaled a tongue or mouth, touched the shirt. So the baby ingested fentanyl that way. And this was a case that the police department could not prosecute because they couldn't prove anything that would have to do with the charge with that. So these are very concerning incidents. And the fact that fentanyl, the patches are left in garbage cans. People don't know how to properly dispose of their patches. And a toddler will see that, think it's interesting, and pick it up. They see grandma or mom or dad sticking on their skin, so they're sticking on theirs too. So where it might not be enough to affect an adult, it can kill a baby or toddler, and it has done that. So systemic issues continue. Language and cultural barriers may limit the ability of immigrant families and individuals to access services. And this has really become prevalent when there's a procedure or a practice that a particular culture will do to think that this will assist the child in whatever illness they have. And not picking on anyone, but the practice of cupping comes to mind. Well, some practitioners don't really understand that, and I think that a better sense of trying to impact our patients and some of our practitioners with a little more cultural sensitivity, because these are not habits that are meant to harm the child. And I think that more questions on the front end would be definitely more positive in nature, and come out with maybe if the baby is ill and the baby doesn't come to a full recovery, that the family is understood, because the family still grieves. We don't understand them, they may not understand us, or they may not understand each other, but their grief is still there. People still need understanding, and if that's a practice that the culture that is taking care of this individual or the family doesn't believe in, then that's a conversation that I think that other help needs to be brought in. But that's just my personal opinion, not the team's. But we're talking about how can we as a team deal with some of these cultural barriers. And there's also, this is not a real difficult one. It's not one that's really harmful. When we talk about Tylenol, some people who are Spanish speaking say, drink the Tylenol. But the Spanish translation for taking the Tylenol in some the language of the sections, I'm trying to think of the section, I'm sorry, it's missing me. But that translation is drink and not take. So, it's like, it's just asking a question, you take it and tell me about that. And then tell you they get a pill and put it in their mouth. So that's that, so you learn from them, they learn from you. So just, that's a small one, but we need to limit the ability. We do not need to limit the ability of these individuals to access services. And so maybe some cultural sensitivity classes or some presentations or information would be helpful. There's an SAI policy requiring DSS to review and screen all reports regarding SAI and investigate, even when a medical provider does not suspect abuse or neglect. Action is not warranted in all cases, but still requires the expenditure of resources and governmental contact with families. Youth in Durham continue to die from unnecessary gun violence. This seems to have increased in the last couple of years, and most of the gun violence is due to gang infighting, warfare, whatever you want to call it. They're kids are in cars shooting at each other, and they're 15, 16, and 17 years old, and they have AK-17s or whatever you call those big guns meant for war. And it's disturbing to us as a team, because when the gunshots are going off in a neighborhood, of course they're going to ricochet, and a couple of these ricochets have killed children. A 10-month-old in bed, killed a 12-year-old in bed. We had a 15-year-old that was involved in a not a drive-by. They were shooting back and forth, and so a mother lost 2 of her children in another incident, and we just don't know at this point how to address this right now. I'm getting ahead of myself again. I apologize for that. But it's really a disturbing trend that's increasing, and the deaths have become more violent due to this, the children and these guns that they have. There continues to be a lack of affordable housing. We've noticed a connection between a lack of stable housing and infant deaths due to unsafe sleeping conditions. An example of this is some families set up house, so to speak, in one of the extended stay hotels. Well, they don't have, to our knowledge, they don't have cribs or pack and plays. So we have a recommendation about that I'll discuss in a few minutes. Also, we don't want to forget the professionals. Each month, when we review cases from the Community Child Protection Team, or the child fatality prevention team, the professionals working on these issues related to child welfare and public health are in highly stressful jobs. When you do a review about two children who are burned to a crisp and the mother walks away from a car accident, I mean, hearing these types of cases, they have an impact on the people who are reviewing these cases and trying to decide about recommendations and trying to look into the systems to see if there are any systemic issues that can be addressed. So we are advocating for the support of not just the people who are on the child fatality teams and the community child protection teams, but the individuals who work in any agency that are dealing with children who are seeing children who have been habitually abused, harmed, hurt, or killed. And this is, maybe part of their job or most of their job. They need support as well. Children continue to die in car accidents related to substance impairment and lack of appropriate restraints. People are still not restraining children appropriately. And some children are still dying from this. A driver who may not be impaired whatsoever, no impairment, no drink, no nothing, but the baby is not, or the child, or the infant toddler is not restrained properly. So if they are in a car accident, the baby goes flying towards the front. And some babies have died because of that. So we start recommendations now. It's recommended that both of our joint teams, the Community Child Protection Team and the Child Fatality Prevention Team, convene a subcommittee to explore strategies and solutions to reduce infant mortality rates and to improve safe sleep practices within the community. The Community Child Protection Team, this joint team does have a safe sleep committee that will resume meeting. As a matter of fact, in a couple of weeks, next week to be exact. We're going to meet to talk about strategies. We're going to look at what other communities are doing regarding safe sleep practices. We've learned so far that culturally, all cultures, there are some people who say, I'm going to sleep with my baby. I'm not going to stop sleeping with my baby. This is what we have always done in my family. And we, as a team, one of our thoughts is, because we haven't really put anything into writing yet, is that we need to think of a way to help these mothers and fathers sleep as safely as possible. We are thinking about helping as a team. The child fatality team gets a little money every year. So next fiscal year, we hope to have a plan in place that will help facilitate the work for this team. And I think, if I'm not mistaken, I wasn't there. I think Commissioner Carter has stated that she is going to facilitate and help us to get some funding to help this campaign, so to speak, move along. And we not only want to improve safe sleep practices, we also want to look at the moms coming in for prenatal care in a timely manner. We can probably practice with that, because the recommendations that I'm going to discuss now, they're not going to be us in a vacuum. We plan to reach out to our community, to our community partners, and we want to work on this as a community to get these recommendations together. Some of our moms, as we know here in the health department, are not getting that first prenatal visit within the first 12 weeks, and that's vital. We've had moms come through with infants that have died at 21 weeks gestational age, and we look at the number of prenatal visits and we see 0. Or a baby dies at 38 weeks gestational age, and we look at the number of prenatal visits and we see 0. So we want to look at and see if there's some way we can connect and see why this is happening. And of course, we can't do that on our own. And we're going to try to find someone to begin partnering with and then spread that out because we want these recommendations to be community recommendations and not just recommendations by our team. Because if we're going to put forth some recommendations, we want to do it as a community, collaborating and working together. To support and continue funding for the valuable resources of a family navigator. Now, this is not the one that we have here in public health. We have a brand new one here in public health that we are very excited about. This is really going to help this recommendation as well. This family navigator that I'm speaking of here is a liaison between Department of Social Services, the Department of Juvenile Justice, and the local LME MCO. And they act as a liaison for families who receive child welfare services. So that's something we're going to advocate for. And again, at Public Health, we recently got a position and we're really excited about that and our contributions that are to come. So those are our recommendations that we have for this year's Child Fatality Community Child Prevention Annual Report. There are additional details can be accessed through the report that was distributed. And I'd like to know if there are any questions for me.
Ms. Scott, I did have a question. Thank you first for your report. It was certainly informative. I'll start by saying it's obviously disturbing to hear about the various ways that we lose children in our community, and certainly they're all tragic. But is there any, and you kind of alluded to it, any thoughts or recommendations regarding gun violence? That's sort of in the news a lot, probably more than any other of the different ways that we lose our children. Any thoughts about partnering with organizations or task force that have had some reasonable amount of success in Durham or even neighboring communities as a way to address the loss of our older children?
Well, the first recommendation to our team was for one of our team members to join the gun prevention team here in public health. And so that's going to be me. And so I'll be doing that. But also would I like to reach out and to see, would like to reach out and see who's had success in working with teenagers, particularly, because I think that if we can get enough gun locks out, enough people are willing to use those gun locks, the gun locks are free. They're free of charge. If we could get those out at community events, we have some programs here in the health department that provide community events, that do community events. We have, Bull City United, we have Triple P. And so one thing that we can do that is a recommendation now is to partner with our existing co-programs here in the health department and to make sure that if we can ask for some gun locks, if they would take some gun locks out with them, and maybe when they go to some of these communities, maybe some people will be willing to take them and use them. I mean, they may or they may not, but nothing hurts if we take them and they don't take them. They have access, and we provide access free of charge. And then, the more we do it, eventually somebody will say yes, because we tend to be very smilingly persistent, cheerfully persistent. So we try to, we try to talk to people, not necessarily say you need, but, this would benefit, you'll see a difference here, when things happen, children play and that aren't really, so we go, our team goes from that perspective and say, children sometimes they are smarter than you think. They probably know that combination you have, because children have a uncanny way of knowing things that you don't think they do. So, don't underestimate your child. They may be 6, but they may know more combinations than, your whole family. So we just try to, just not make light of it, but just say, don't underestimate. Better to be safe than sorry. But so we're thinking about doing that. We're also thinking about looking at other communities, because there are other, there's another Bull City United team, I think in Charlotte. And there may be one in another city that's getting ready to start up, but may have already started up. And we want to reach out and see what they have seen in Charlotte in particular, because they've been up for a minute. So we want to reach around to community action groups, to other gun prevention groups, and to just see, have you seen anything that works for you? So what we're really doing is just going to do a wide reach, just who do you know? Who do you think will help? Okay, you call them. And then when we get back together, well, what did you find out? And convene like that. And maybe we can get some hard and set recommendations that we can offer and can start announcing to the community. But that's just in the early stages, as I said. So that's one thing. I think that one thing that that I don't know if it will help or not, but the children who are involved in gang activity, some of them are honor students. So it would be interesting to know any child's reason for being in a gang. But I think the common perception is that most of these children were from socioeconomically, the lower socioeconomically what in housing projects. But all these children don't live in housing projects. Some of the kids that we have seen come through with these gun deaths have been very smart kids, and they have not lived in a housing project in Durham anywhere. So it'd be very interesting to see what pulls children into, all children, any child into gang violence. It's not a one picture. Yeah.
Yes, ma'am. Thank you. I thought I saw Commissioner Alam's hand up. I did see she made a comment in the chat. Commissioner Alam, did you have a question?
Yeah, thank you so much, Dr. McDougall. I was just wondering, and sorry if I missed this part of juggling maybe also, have you guys and thank you so much for this presentation, Ms. Scott. Has this been presented to like the Child Fatality Task Force and the Lincoln Community Health Board as well? Because I know.
No, it hasn't.
Okay, because I know Commissioner Carter, she's raised this to our board, like generally like in our commission meetings, because it's been coming up in the board she serves on a lot around the safe sleep practices and what the county is doing to provide more education to residents about safe sleep practices. So whenever you send this presentation, I can forward it to her, but also I think maybe it'd be a really good presentation for those boards as well, since those members are talking about it.
Okay, could you repeat those names, please, if you don't mind?
The Child Fatality Task Force and the Lincoln Community Health Board.
Thank you.
Thanks for that suggestion, Commissioner Alam. I am currently serving on Lincoln's board of directors, so Cheryl, I'd be happy to help make that connection, particularly like you said, Commissioner Alam, around the safe sleep education.
Okay. Thank you.
Ms. Scott, this is Dr. Ray. Thank you very much for the presentation. Certainly it's disheartening to hear that we still continue to lose infants despite all that we've learned around safe sleeping practices. Just a question, mainly based on my lack of knowledge of, from a resource perspective, if a family is identified as having certain beliefs or misunderstandings that may lead to unsafe sleeping practices, are there connections when that's identified, say either during prenatal visits or at the hospital during discharge, where number one, they can get education and or they can get some actual, say, equipment, cribs? There are ways to do co-sleeping, but in a safer method. Are we in public health partners to be able to help them, or are there outside partners that they get referred to?
Well, the Department of Social Services, they have cribs and a few bassinets, and they have pack and plays. So whenever they get a call that someone needs a pack and play for whatever reason, they give it to them. So, but I found out that in the hospital from the physicians on the Community Child and Child Fatality Joint Team here in Durham, that there's not as much safe sleep education given as we thought it was. And so there are physicians at Duke and they're trying to address that. But if what we do is of course give the pros and cons. And I think that if an individual says, you know, regardless of, you know, we want you to be safe, if you have this even a dresser drawer, you know, beside the bed, or, you know, don't put the baby on the pallet because the baby may turn over and can't turn back over, but don't put anything in the crib if they have a crib. Get a pack and play, don't put anything in there, you know, while they're asleep. That way if they roll over on something, you know, it won't be a stuffed toy or something like that. But I think that I'm not sure, to tell you the truth, if anyone with the cultural differences have people to, you know, if people that in the same culture come speak with them, because a lot of women, these include American women, women of Spanish descent, all women, if they don't want to co-sleep, they make that very clear. And the Department of Social Services really can't do anything because they have not demonstrated neglect or any intent to harm. They just want to be close to their babies. And so we're trying to think of ways to help you be close to your baby without mistakenly killing your baby. Not that we say it like that, of course, we're more sensitive than that. But some women absolutely refuse. They say, my mom did it, my grandmom did it, I'm going to do it too. So, you know, the conversations that I've heard about that have been discussed in the teams, if a woman does not want to do it, they've had very little success convincing her to do otherwise. So it's a tough issue. It's tough. It's a tough issue. I mean, it's tough. Yeah.
Thank you very much. Certainly an uphill battle. You certainly trusting what your mother and your grandmother say versus someone you meet in the hospital's challenging uphill battle. But thank you very much for informing us about this.
Thank you.
I had one more thing, Dr. Mardugo, if that's okay. Okay, thank you. Just on that, I remember, I don't know if we're tracking this, but I believe it was last month or the month before, there's actually this bassinet that apparently is like scientifically like proven and stuff to help prevent SIDS that just received FDA approval. And so now there's been conversations that insurance, since it's received FDA approval to prevent SIDS, people will be able to get this bassinet through their insurance. So if we are monitoring and tracking that, so like if it does roll out, it's the SNU bassinet, that if that ever rolls out, that can also be part of our educational materials to tell folks like this is a way to get a safe bassinet that can stay right next to your bed.
Oh, thank you for telling us
Awesome.
that. Yeah, the health plans that work with Medicaid, they offer incentives to their beneficiaries, and this is something we work with. I'm blanking on them again, but we work with about 3, our CMARC program, our case management for at-risk children's program. We work with, and so does CMHARP, the program that works with high-risk pregnancies here in the health department. We work with the healthcare plans who are managed Medicaid organizations, and they're offering a lot of incentives. So we could make the recommendation to them that they look into this and perhaps add it to their list. So thank you. Thank you for that.
Very good. Very good. Does anyone else have any questions regarding the presentation by Ms. Scott or comments? All right. Thank you again, Ms. Scott, for your presentation and your time this evening.
Thank you very much. I appreciate you all listening. Thank you.
Yes, ma'am. All right. Well, so we'll continue on with our agenda. We have next our public health vacancy report, and it's looking pretty consistent with what we've seen earlier this year, hanging around 19% vacancy. But I'll give way to Deputy Director Stevens if you had any comments that you might want to make
Thank you, Chair McDougall. I don't have any particular comments. I know during this month, things did seem to slow down a bit in terms of folks leaving us, and we continue to recruit and hire just as well as we can. So I agree with your assessment that things have stayed pretty consistent.
Okay. Thank you. Does anyone else have any questions or comments regarding our vacancy report? All right, we'll move on to our NOV report. Again, it's staying pretty consistently going well, I'll say. We're seeing more and more of these issues being cleared, and but as per usual, I'm going to give way to our Attorney Wardell to make any comment regarding our NOV report.
There really hasn't been a big change since last month. Things are going fairly smoothly. We do anticipate a few bumps in the road. There have been a couple of cases where there are very few alternatives for the homeowner. They can temporarily bring their properties into compliance through temporary pump and haul, but a permanent pump and haul is an expensive remedy for many of these properties. And so we do anticipate that there will be some compliance issues that may arise because of that. And there has been an effort that's been going on almost as long as I've been at the county to develop a funding source for these homeowners to get assistance in bringing their wastewater systems into compliance if they don't have the money to do it. I don't know where that is at this point in terms of putting that program together, but I know it's something that has come before the commissioners several times. The board has talked about it several times. So it's getting to a point where we're actually going to have some options for these homeowners, because they are not in a position to be annexed or have accessible city water and sewer. So that's not an option, and the soils are just not receptive to traditional systems, traditional wastewater systems. So problem, and it's right around the corner. So I think we need to regenerate that discussion. I know Chris Salter has been in that process. I was involved in that process when it first began. So I think that's something that's coming on the horizon, but as of right now, all is well, the quiet before the storm. And so we'll ride it out, and hopefully we'll have something in place by the time these properties start really needing some assistance.
Yeah, Chair McDougall, this is Chris Salter, if I could just interject.
Yes, sir.
Some.
Yeah, jump right in.
Okay. We did put together a program, a proposal. It's very detailed. It's in a PowerPoint presentation, actually, and that could be easily shared. Director Jenkins is aware of it. He's seen it. We did take that to county finance several years ago, and we got some praise for it. And it was suggested that was a good way to spend county funds, helping people who needed the help. We need seed money to get the program started, and we got to figure out who's going to manage it, but we can certainly share that PowerPoint with everyone to see, give you some more in-depth look at what we've proposed. But it is very detailed and a worthy endeavor. Yeah.
Okay, thank you. I look forward to seeing that soon. Thank you.
Yep.
Any other questions or comments regarding our NOV report? Thank you again, Mr. Salter and Attorney Wardell. Okay, we'll move on to our Health Director's report. Again, we have Deputy Director Stevens on the call to answer any questions that anyone in attendance might have. Deputy Director, if you have any comments that you'd like to make beforehand, before the questions come, feel free.
I don't have any comments in particular. I think you have before you a robust report. As per usual, a lot of great things going on, and all praise goes to the team. So happy to answer any questions or allow our subject matter experts to do so.
So I did have a question or two on page 3 of the Health Director's report, in the portion about the health education and community transformation, improving community outcomes for maternal and child health. In the statement of goals, it mentions contracting with the Family Connects Newborn Home Visiting Program. Now, when I was reading this, it gave the impression that we're reaching out to every parent who's contributing to live births or who has live births in Durham County. Is that true, that we're reaching out regardless of socioeconomic status and income?
Yeah, I'd be happy to speak on that, and would invite Nursing Director Hattie Wood or others to chime in. So the Family Connects model is indeed that. It's a universal postpartum home visiting program. So irregardless of socioeconomic status, race, ethnicity, first child, fourth child, the model is that there are benefits to working with families postpartum universally. I do know that Family Connects Durham has had some challenges over the past couple of years, and have, for simply a staffing capacity related issue, haven't been able to be as robustly reaching out to every program, but it does remain a universal program in our community in terms of there not being any sort of requirements for families to receive a home visit. So I hope that answers your question, and again, would invite anyone else to chime in.
Yeah, it does. I was thinking, wow, there are a lot of live births, and I can't imagine the number, but there are a lot of live births in Durham County.
Yes.
And to imagine that we're actually able to reach everyone was monumental if that was really taking place.
Some of you may recall that program originally was housed in the health department when it was early on being investigated as to whether it was a helpful model universally to all families. And then it moved over to our partners at the Center for Child and Family Health and has been housed over there for about the past 15 years or so.
Well, I have one more, and it's more of a comment than a question. With the last few pages regarding the population health and epidemiology division, I was really impressed with with this section of the report, with the results of the data analysis for so many years, actually being used by I'm sure by the Board of County Commissioners and other agencies, and we're seeing hundreds of millions of dollars going toward addressing the issues that are being outlined in this assessment. So it's just good to see that all of this data is actually being used to help to improve some of the health issues that are taking place in the community.
Yes, thank you for pointing that out. We know that our population health team is second to none under the leadership of Marissa Mortiboy, who is actually attending a conference this evening and not able to be here with us. But the work of the community health assessment has been, again, this past year has been really monumental. And we know as the findings are being pulled together for our next report, that data is really so helpful for many partners around the Durham community.
Awesome. Any other comments or questions regarding the health director's report for May? All right, thank you, Deputy Director Stevens. We're moving on here. So we don't have any committee reports, I don't believe. Correct, Ms. McLean?
No, sir.
All right, and no old business. So we're going to move on to new business, agenda items for the next meeting. I would certainly like to start by recommending that we get the wastewater subsidy program that Mr. Salters spoke of. If we could maybe have that added to next month's agenda. Be
Yes,
interesting
sir.
to hear.
Would you
more about
like
that.
would you like that to the PowerPoint presentation presented, or do you just want it attached to the agenda so you could review it on your own?
Actually, both.
Okay.
Typically attach it and then have a presentation. Yeah, that'd be great, I think.
Okay.
That way we can
Yes.
have questions answered if there are any afterward.
Yes, sir.
Yeah, thank you.
One other item, Chair McDougall, if I may.
Yes, ma'am.
Director Jenkins reminded me that we had previously been asked to give an update on our HIV ending the epidemic services. And so if that is something that we'd like to plan for our next agenda, I wanted to be sure to not let that be forgotten.
Okay. Yeah, I think we can certainly add that.
Great, thank you.
Yes, ma'am. Any other suggestions for agenda items to be added to the agenda for next month? All right. Well, we're at that time. I will entertain a motion to adjourn if there is no other business for us to take care of this evening.
So moved.
Second.
All right, it's been moved and properly seconded. Is there any unreadiness to adjourn? I didn't think so. We're ready for the question. Ms. McLean.
Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Commissioner Alam,
Yes.
Dr. Jackson,
Yes.
Dr. Braithwaite,
Yes.
Dr. Orto,
Yes.
Mr. Brown,
Yes.
and Dr. Glover.
Yes, ma'am.
And welcome to Dr. Glover. He's joined us. He's had a lot of schedule conflicts, but he's here with us, and it's good to see him on camera. And welcome to the board, sir.
Thank you for having me. I
Welcome.
look forward to making an impact with everyone on this call. Thank you so much. I appreciate the opportunity. It's a blessing.
Yes. Thank you.
Yes, sir. All right, I think we stand adjourned.
Great.
Thank you.
Thank you so much.
Thank
Have a good
you.
evening.
Bye, everyone.
Have a
Goodbye.
great
Bye.
evening.
Take care.
Bye.
Dr. McDougall.